Welcome. I'm Matthew G. Mosman, Certified Peer Specialist, and this is my presentation on ethical issues that come up working with people with major or serious mental illness. Originally, I had a bit more punny title for this, as is my wont, like making it in the majors. But the more I worked on this, the more I realized that, in my experience, many of the ethical issues that come up and the ethical violations that happen working with people with serious mental illness come from paternalism, which is this kind of like father knows best attitude that can be very seductive when you're working with people who have a very serious mental health condition. So in this presentation, I'm going to be examining many of the issues ethically that may come up working with people with serious mental illness through the lens of paternalism being one of the big temptations for clinicians and providers who may mean well, but this may lead them into error ethically working with people with serious mental illness. Okay, so I figure we'll start with kind of just a definition of terms. Prof assigned me to do a presentation on major mental illness. More often I've encountered it being referred to as SMI, which is either serious or severe mental illness. I've decided to just kind of go with the National Institute of Mental Health standard. They call it serious mental illness. They define it as being mental, behavioral, or emotional disorder resulting in serious functional impairment. Serious meaning, substantially interfering with or limiting one or more major life activities. And they use this when they're examining prevalence of mental health disorders, and it's contrasted with AMI, or any mental illness, which could be serious, but it also just includes any basic diagnosis that is a mental health issue. So a lot of times this is going to be the big ones like schizophrenia, schizoaffective spectrum disorders, severe bipolar disorder, but lots of mental health conditions can be defined as a serious mental illness if they meet this standard of, substantially interfering with or limiting major life activities. Major depression can be serious mental illness if it meets this threshold. Obsessive compulsive disorder, anxiety disorder, even phobias. There's not a list of mental health disorders that are serious and ones that are not. At the end of the day, it really depends on the effect on the individual's life. So in theory, any mental health disorder can be a serious mental illness if it impacts an individual enough to seriously inhibit their ability to carry out the functions of everyday life. If it prevents them from working, if it prevents them from forming relationships, living on their own, taking care of themselves, pretty much almost anything in the DSM could meet that standard if it is causing that kind of impact in an individual's life. And so when we talk about major mental illness, or I'll probably refer to it mostly as serious mental illness, or SMI, throughout this presentation, that's what we're talking about. To continue with defining our terms here, what is paternalism and why is it a threat to treating individuals with serious mental illness ethically? Paternalism, as defined by dictionary.com, the dictionary I have on hand, is the system, principle, or practice of managing or governing individuals, businesses, nations, etc., in an outwardly benevolent but often condescending or controlling way. In my experience, this is a big temptation that arises when clinicians, counselors, providers in general are trying to provide treatment to people with serious mental illness. Because oftentimes these individuals may be struggling a lot, they may often exercise lapses in judgment. It may seem like they are incapable of taking care of themselves, or that they will not follow treatment recommendations if given all the information, because they're not capable of making correct choices from the perspective of the treater. And while it is important for us as treaters to take into account the limitations of the people that we are working with, I think paternalism as a problem comes out of stigma. Stigma is, this kind of crown of thorns that we attach to individuals that are different. We hear this word a lot when we're dealing with people with mental health issues, that they suffer from stigma, which means that they could be subject to a number of things. One is discrimination. I work with a colleague who's another peer who doesn't like the word stigma. She thinks that we should call it what it is as far as she's concerned, right? That it's bias or discrimination, that the word stigma is essentially a whitewash of practices that would be unacceptable if they were put on any other population, like people of color or people of a different religion. And because it's mentally ill people, we call it stigma, but we should really call it discrimination. I don't 100% agree with that, because I do think that stigma can lead to discrimination against the mentally ill, like where they won't be offered a job, or they'll be not denied certain opportunities, they won't get housing, or things like that, where people see that somebody is mentally ill and they, outwardly discriminate against them. I think we can all pretty much agree that that's wrong. But stigma also leads to paternalism, because when you work with individuals that, say, have schizophrenia or severe bipolar disorder, it can come to the point where providers don't trust in these individuals as a class to make good decisions for themselves. And instead of discriminating against them, they try and do what's best for them, try and act in their best interest without respecting their self-determination. That might mean things like not fully explaining the side effects of a medication because they think that they won't take it. They think that it's in their best interest to take this medication, so they're going to describe it in very favorable terms and maybe omit the side effects to get this person to take a medication that they think they need. This happened to me myself. I was coaxed into taking an antipsychotic medication because a provider told me that it was just a sleep medication, because they didn't trust that I would make the correct decision. And so they succumbed to a paternalistic impulse to describe it to me in a way that they felt that I would do what they thought was in my best interest. But at the end of the day, I think that this is counterproductive and it is unethical. It's this idea, like I've put here, of kind of like father knows best. And one of my biggest examples of this would be with cigarette smoking. I'm going to talk about cigarettes and paternalism for a hot minute because it's one of my pet peeves, and I think, although it may seem insignificant, it is really emblematic of the problems that can come out of well-intentioned paternalism. To start, people with serious mental illness are significantly more likely to be cigarette smokers than the general population. Not that that really matters, but it does add a little extra import to this. And as a person with serious mental illness, if you get sectioned into a hospital, or you even voluntarily go into a psychiatric hospital, to an inpatient unit, or many residences, and unfortunately now even rehabs, one of the first things they're going to do is they're going to take away your cigarettes. And I should add that being involuntarily hospitalized is already an extremely traumatic experience for just about everybody who it's happened to. I can say from personal experience. And in addition to that, if you're a cigarette smoker who's dependent on smoking cigarettes, being involuntarily deprived of your cigarettes is doubly traumatic. However, today, on most hospital campuses, they will not allow you to smoke for the duration of the time that you are in there. Some of them will allow some limited smoking privileges if you have a guest or if you're on a walk, but increasingly treatment facilities are going for smoke-free campuses. And it seems like a real high ideal, right? People are coming in for treatment, sometimes for very severe disorders like schizophrenia. And if we're going to get them healthy, we may as well do everything we can to get them healthy. Let's make sure they leave here a non-smoker. But the truth of the matter is, if you take away someone's cigarettes who's dependent on cigarettes, they will not be able to concentrate on anything else but getting another cigarette. They'll do whatever they have to do to get out of there and have another smoke. They won't be able to concentrate on the treatment, on whatever interventions are being made in order to improve their condition. And honestly, if someone has a serious mental illness, nicotine cessation is the last thing they need to worry about. I can say this also having worked in PACT in the community with a program of assertive community treatment. I'll meet with parents who have had an adult son or daughter who's been hospitalized 3 or 4 times in the last year. And I'll meet with them and ask them, like, what would you like to see come out of treatment? And they'll be like, well, they gotta quit smoking. And I'll be like, listen, I don't work for the American Lung Association. And if you really want to make sure that your son or daughter who's been hospitalized and has been extremely unstable is going to go back in for a 4th or 5th hospitalization this year, take away their cigarettes. Because that's how disruptive nicotine cessation is. It's very difficult for anyone. It's extremely difficult and destabilizing for someone suffering from a serious mental illness. And so the idea that in our psychiatric hospitals, where people are being treated for the most serious mental disturbances, that we're also going to burden them by taking away a substance, carcinogenic as it may be, though relatively innocuous psychiatrically, until it's taken away, is just ridiculous. It is completely counterproductive, and at the end of the day, I think it's unethical. People will have better outcomes if they're maintained on the drugs with limited consequences that they come in on, and nicotine is one of those. People may be offered alternatives like the gum or the patch, but it's not the same. They won't have continuity of the comfort that they are used to from cigarettes. So I think my prior diatribe about paternalism and smoking and how people would have better outcomes if they were allowed to continue to smoke while inpatient kind of leads us neatly into this idea of how does paternalism lead to poor outcomes. And I know this presentation is supposed to be about ethics, but I think ethics are designed to provide good outcomes, both for providers like counselors and also for the people that they serve. And so while paternalism leads people to make unethical decisions, it also leads to poor outcomes for the people that they serve. And those two things are linked. One of the things is, like I've said, it's counterproductive. Trying to make decisions for people because you think that you know what's best for them better than they do ultimately leads to a loss of trust in the system. Kind of like one of the examples I described when a provider misdescribed a medication that they got me to take. You know, that didn't derail my recovery, but a lot of people that I've worked with have had similar experiences that led them to distrust the system. And when I work with med students who shadow me occasionally, one of the big things I tell them is that yes, you can dissemble about a medication or a treatment that you think your patient needs in order to get them to agree to it, and that may make your day easier, but it's going to make life harder for every other provider that ever encounters that patient. And it's probably also going to make life harder for that patient too, because once they discover that they've been deceived, They're not going to trust providers in the future, and they're going to avoid treatment probably to their detriment. Just like with cigarettes, one of the big things I have with it is that lots of people will avoid the hospital, not because they don't want help necessarily, but because they don't want to have their cigarettes taken away. People probably die because they avoid the hospital when they need it, because they know they won't be able to smoke. And same thing, people probably die because a provider lied to them or omitted information about side effects of a medication, and they concluded that, you know, all doctors, all counselors, all therapists are liars, and so they're going to avoid treatment, you know, to their detriment, to their harm, and maybe death. And I also think that this greater good mentality that characterizes paternalism is a really slippery slope. I think it often starts with what seems like a minor incident, like what I described with a provider trying to get me to take an antipsychotic and just not telling me that's what it was. But over time, it evolves into an attitude of, I know what's best, and so I'm going to do what I think is best, and damn the consequences, damn the guidelines, the ethics, my patient's thoughts. I'm going to do the most good, no matter what anybody thinks, and at the end of the day, that leads to an attitude of, you know, I'm going to do whatever I want. And it can cause a lot of harm, and I've seen it cause harm. And it can lead to certainly a lot of ethical violations as well. And we'll go into some of the specific situations where that might be a temptation as we go forward. So here we are at the hospital, which is where we may be often if we work with individuals with serious mental illness. Obviously, people with serious mental illness are more likely to require hospitalization than other populations. They're more likely to need to be sectioned and involuntarily hospitalized and committed, maybe even court committed to a facility. And those of us who choose to work with this population of people who have serious mental illness have an ethical obligation to be very familiar with this process. Obviously, everybody who chooses to become a licensed counselor has to have some familiarity with the process of sectioning and commitment and hospitalization. But if you work with someone who has a serious mental illness to the point that they are debilitated by it, you have, I think, an added responsibility not only to be familiar with the processes in terms of knowing the statutes and reading the textbook. You should also be familiar with how this process plays out on the ground. You should know about the facilities in your area. You should know about the hospitals, the ERs, how they operate, what hospitals are in the area, what psychiatric beds there are, how available they are. Make contacts with them so that if you think your client needs a bed, you can contact them in advance to try and figure out if a bed will be available, because oftentimes they are difficult to get. And another thing is, even if you do not, as a regular matter of course, work with people who have serious mental illness, any counselor, any mental health professional should be prepared for this process. What I have seen many times is we have providers like counselors, therapists, that mostly work relatively low intensity cases, and they get a case that turns out to be a little bit more than they are used to. And this person goes to the hospital and they kind of throw up their hands and say, well, I don't know what to do, you guys take over. I think all counselors have an ethical responsibility to contribute even once your client goes into the hospital or another facility like that. You don't just get to wash your hands of your client because they go into the hospital. You have a responsibility to be proactive in providing information to the team that is treating them in the hospital. You need to be available to those providers. You need to also be available to your client, who is likely in a lot of distress and may need you. Some hospitals and the treatment teams may try and rebuff you and tell you that they have things in hand and we really don't need your help. Don't just take them at face value on that. That again is where the key word of this presentation comes in: paternalism, right? Inpatient teams often want to take over where they see that an outpatient provider has failed in their view. And they're going to try and do what they see is in the patient's best interest. If you, especially if you've been working with someone long-term, you have a responsibility to stand up for them against, not necessarily in opposition to, but to represent them and provide the longitudinal information that you may have, and also stand up for their rights and their self-determination, and familiarize yourself with what rights they have when they're in the hospital, and make sure that those are being respected, because that is still your patient when they're in the hospital or not. So sliding right in and out of the last slide into this one, like we said, in and out of the hospital, patients have a basic right to be informed about and direct the course of their own treatment. I feel like patient rights is something that we're all taught, and it seems something that's really basic and almost something you don't really need to pay a lot of mind to until you start working with somebody who has a serious mental illness. In which case, it's very tempting to start to try and make decisions for them or manipulate a patient who you think is not capable of making good decisions for themselves. And that might not even be the case just for serious mental illness. It can also be the case for any patient that you think is making bad decisions. And so instead of taking an informed decision-making process, you want to try and manipulate them to make the decisions you think are going to be best. But that is, the path to the dark side. When a patient's ability to understand or make informed decisions is in question, you have an obligation to inform them to the best of your ability. And a big part of this is plain language, right? We don't have to cite them the DSM. We don't have to rail off long strings of clinical or medical information to them, but it is our obligation to inform them to the best of our ability about their rights, about the treatment options that are available to them, and what we can and cannot do for them. And I say here, in pretty stark terms, a lie by omission is still a lie. I think one of the biggest temptations for counselors or any mental health provider is not necessarily to lie to a patient, but to just give them the options that you think are the best for them and not lay out options that you don't think are good options for them. But patients have a right to know about all options for treatment, not just the ones that you think are the best. You should let them know about all treatment options, and not just treatment. When you're counseling somebody and they have a dilemma, you should give them all options as you see it, not just the ones you think they should take. Because if you only enumerate the options that you think are favorable from your perspective, then you are influencing their course of action in a way that may not be ethical. And another thing is something that I was taught in my peer specialist training, which I think is just a good thing for anyone to consider, is a concept called the dignity of risk, which is particularly relevant when we're talking about people with serious mental illness. And I will go into this in greater detail in the next couple of slides, but don't allow working with people with serious mental illness to bring about this risk-averse ideology where you are afraid of encouraging or enabling any activity or course of action that may cause decompensation or rehospitalization. Because when you do this, if you don't allow people to take risks, in particular people with serious mental illness, you kind of perpetuate a perpetual stasis where they may not decompensate, but they also won't improve because they're not allowed the opportunity to improve, because they aren't allowed that dignity of taking the risks that would maybe allow them to make more progress. Because not only you as the treater, but also maybe people in their lives are reticent to allow them to, say, like, apply to a job or take another opportunity or get out of the house. Even if a given course of action may potentially cause symptoms to occur, if it also allows the possibility of improvement, you should allow a individual to take that course of action if that's what they want to do, because if you deprive them of the opportunity to take risks, you deprive them of all dignity. And no one has the authority to do that. So speaking of depriving people of dignity, we come to the idea of a Rogers, right? In Massachusetts, the idea of a Rogers or a Rogers order or Rogers guardianship is something that you may encounter when dealing with people with serious mental illness. Where this comes from is a person, her name was Ruby Rogers. She was the representative in a lawsuit back in 1975 about patients' rights and whether people who are committed to a psychiatric facility have the right to refuse treatment. Before 1975, when Rogers v. Okun, this lawsuit happened, any individual committed to a psychiatric facility was basically considered not to have the right to consult in their own treatment. Once someone was committed to a facility, the treaters in that facility got to decide what happened with them. They got to decide what treatment to administer to them, whether they liked it or not. And what this often resulted in was patients being dosed with antipsychotic drugs, sedatives, without really having much say in the matter. We can say they certainly many of them may have had the best interest of those patients in mind, but the patients didn't have any say. Once they were committed, it was considered that they basically had no rights, considering whether or not they would be subjected to a given treatment or not. And obviously, we would say this is problematic, right? At the time, it was considered ethical because those patients were remitted to the care of this institution, and those treaters were responsible for their care, and they were considered incompetent by default. The court judgment in Massachusetts says that just because you are committed to a mental institution does not necessarily mean you are completely incompetent to consult in your own care. So today, if someone is in the hospital, whether it be a psychiatric hospital, state hospital, any other institution, that doesn't necessarily mean that they have no rights to say about their own treatment. They can refuse certain medications, they can refuse certain treatments. Specifically, we're mostly talking about antipsychotic medications and treatments like electroconvulsive therapy, etc. Unfortunately, although many people would say that this is like a great victory, and it really was a sea change that influenced law not only in Massachusetts but all over the country. This kind of thing still happens. And although it may not be legally mandated, there are some incentives for psychiatric treaters to treat the people under their care in this incentive in ways that may not be ethical. In my experience, one of the big examples is, I've worked with a lot of people who are in group homes, for example, that have their own prescribers, and they prescribe a lot of powerful antipsychotic drugs to people there. They may have 5, 10, 15 people under their care, and they have the same incentives as the large facilities that Ruby Rogers was in, which is that they want to be able to, handle large numbers of people without too many troubles. And antipsychotic drugs, they can do miracles for people who really need them. But many of them also have the side effect that they are very sedating. And if you're trying to manage a population of, 7, 8, 9, 10, 11, 12 people with serious mental illness under one roof, and you don't have the proper resources to do so, it's very seductive, the idea that you can give them these sedating drugs so that they will all be very manageable. They will lay in bed most of the day, or they'll lay around. And this is what happened in the large-scale psychiatric hospitals in the 70s before deinstitutionalization, that they had a large incentive to give everybody these sedating antipsychotic drugs to keep everybody sedated and under control. And this is a classic example of paternalism. And before the Rogers v. Okun case, it was institutionalized paternalism. It was legalized paternalism, that, these people were considered to be insane, basically, and removed from society and crowded into these facilities. And how do we manage all these people? We're going to give them large quantities of drugs that will keep them sedated and quiet and sleepy, and so that they're not going to cause a lot of trouble, and we can manage this large population of people. Today, it's no longer a government institutional policy to sedate people, but it still remains in private, semi-private, all kinds of facilities where they can't legally force people to do this, but they have lots of other incentives to do it, where maybe these are people who have nowhere else to go. Largely, it's people who their families can't take care of them or no longer have a willingness to take care of them, and the people have nowhere else to go, and so they're coerced that way into taking these drugs. And as providers, we have an obligation, if we take these people into our practices, to try and counteract this practice. I personally have worked with a few people that have come under my care who were in facilities like this, and we kind of broke them out. We call them ice boxes, places where people who are severely mental ill are just over-medicated with antipsychotic drugs to the point where, they just don't do anything but lay around all day, because that's what is convenient for the people who administer these facilities. And we have to take into account, these factors, that people are still to this day being subjected to these kind of psychiatric abuses. They may not be being tortured, but they're being subjected to unethical practices. And when they come under our care, we have an obligation to counteract these practices and try and end these kind of practices that are a legacy of the paternalistic practices of the psychiatric past. So all this talk about Ruby Rogers leads us to the concept of guardianship, Rogers guardianship, and the related concept of conservatorship. So we as counselors, I think, are ethically obligated to protect the self-determination of the people that we work with. But that may be limited sometimes if our clients are under an actual guardianship, conservatorship, or a Rogers guardianship. So let's define a few of our terms, right? So a guardianship means that the state has appointed an individual to represent another individual who has been considered to be incapable of representing themselves in certain affairs. It could be either a plenary, full, or general guardianship, which basically means somebody is fully representing this person in all their personal affairs, like they can sign documents for them, lease agreements, etc. That's relatively rare because in Massachusetts, the law highly favors forms of limited guardianship, which means that although somebody may be appointed guardian for someone, if at all possible, that person will have some influence on these decisions. They will have some kind of consultative authority in decisions made over their own life if they have any capacity to do so. There's also conservatorship, which is something that's appointed when somebody is considered to be irresponsible or incapable to manage their own legal and or financial affairs. In that case, somebody will be appointed their conservator, whether it be just like guardianship. It will often be a family member, but it doesn't have to be. It can also be someone appointed by the state or a professional hired to fill that role, who will be responsible for making legal and or financial decisions for that particular individual who is deemed incapable of making those decisions for themselves. Often in the case of somebody who has maybe significant resources that they're deemed incapable of disposing of on their own authority. Interestingly, there's another concept that I think is related to this. There's a thing called a rep payee, a representative payee. This is a person that may be appointed by the state to cash and manage disability benefits, which we're going to go into in a next slide. Certain individuals with serious mental illness may be deemed incapable or inadvisable for them to manage their own disability benefits. So someone, either a relative, a friend, or often a treater like a social worker or outreach worker, will be appointed rep payee to take custody of funds that are given to them from their disability benefits so that they will not misplace these funds according to their own disability. This is often going to be the case in somebody who is severely disabled, who really cannot manage their own finances, or a lot of times somebody who has a serious mental illness who also has a comorbid substance disorder, to prevent them from taking their disability benefits and spending it all on their drug of choice. But an important emphasis here is that just because somebody is appointed to be a guardian or conservator does not necessarily make them a Rogers guardian. That is a totally separate process. So even if somebody is a full guardian, that doesn't make them a Rogers guardian. As we talked about with Ruby Rogers, people have the right to refuse treatment unless there is a Rogers hearing which appoints a Rogers guardian. And, it may seem like, no, we should never force anybody to take medication, but some people really do need somebody else to make those decisions for them. For example, I've worked with people who have really severe psychotic illness who will get really decompensated and be in the hospital and refuse all treatment. And, they stay in the hospital forever unless somebody was able to authorize for them to be administered the medication that they need. These are the kind of situations where we will appoint a Rogers guardian. It may be a family member, it may be a court-appointed individual who's able to make that decision so that this person who really truly is in need of these medications or treatments to be administered them when they really need them, even if it's not what they express that they want in the moment. But as stated in the previous slide, we apply the standard of substituted judgment. So that Rogers guardian is still bound to the idea that if they appoint somebody to administer a given treatment, it should be a treatment that this person would agree to if they were in their right mind. So we talked about guardianship, Rogers guardianship, and conservatorship. Now we're going to talk about disability benefits and the Department of Mental Health. When you work with individuals with serious mental illness, they will often qualify for disability benefits, and they may qualify for services through the State Department of Mental Health, especially here in Massachusetts. Whether this person should take advantage of those benefits or should receive services through the state is a judgment that you will have to make as a provider. But I also believe that it's an ethical obligation to inform any client who may be eligible for these benefits about their eligibility. And this can be kind of tricky. You would think, right, if somebody's eligible to receive disability benefits, free money, right? You should always tell them about it. It's not always that easy. There are significant drawbacks to an individual receiving benefits from the state. And this is a reason why many providers are tempted to avoid letting an individual know that they may be eligible for these benefits. I've experienced these frustrations myself. Once somebody receives monetary benefits from the state, they may be reluctant to pursue employment or other opportunities that might advance them or create greater fulfillment in their life. Individuals who receive disability benefits like SSDI might be limited in the amount of money that they're allowed to have in their bank account. And so they kind of get stuck. That doesn't necessarily mean that you shouldn't tell somebody that they're eligible for these benefits. You should let them know, and you should let them know about the potential benefits and also the potential drawbacks. If someone's eligible for these benefits and they really need them, certainly you should not only let them know about them, but if it's within your capability, you should let them know how to access them. Also, a lot of times, people who are really afflicted by serious mental illness, they are eligible for benefits through the state, through the Department of Mental Health. This can include free mental health services ranging from counseling to residential to DMH, program of assertive community treatment. These programs can be very highly beneficial to an individual, but they require a lot of paperwork. They require a lot of work on the part of the individual that is referring them, as well as the individual that may be receiving services. If somebody really needs these services, it is the ethical obligation of the treater to facilitate them receiving these services. A lot of people, though, even if they're able to provide good services, if they have a client that is seriously mentally ill, will try and just punt them to state services. It's a really difficult and blurry line of whether you can provide adequate services versus whether the state would provide better services. So, I'm going to end this presentation on, like I said, a real blurry line. Like, sometimes you're going to be presented with a client that you're not sure that you can handle yourself. Maybe they'd be better off in the hands of somebody else, like the state. But also know that there's a lot of bureaucracy and difficulty involved in accessing state services, and those state services might not provide the kind of attention that you and or maybe whatever team or institution you're working with can. So when you're working with someone with serious mental illness, it's always going to be kind of a blurry line between can I handle them outpatient, should they go inpatient? Should I take control of this situation, or should I try and kick them to like state services like the Department of Mental Health? That's never going to be an easy decision. It's an ethical decision, but it also brings into account a lot of other factors. So you're going to have to make that decision for yourself as a provider, whether you can provide better service or whether they are better taken care of by somebody else. Especially with individuals who are not only seriously mentally ill, but maybe like reach a higher threshold of being a really difficult to manage individual. It can be a difficult game. I've called it like the clinical hot potato, where if somebody becomes notorious as difficult to manage or difficult to deal with, different services will try and kick them around. And as we know, it's unethical to abandon a patient. So nobody wants to get stuck with that difficult patient that they can't abandon. So they get stuck with. Even the state will play this game. So be prepared to walk this blurry line, especially if you plan to work with patients, and I won't call them patients, just individuals, people at the center of concern. If you concern yourself with people who have serious mental illness, things are never black and white, and don't expect them to be. But things will always be interesting. And as many difficulties and failures as you may encounter, it's still worthwhile.